Okay, folks, one more big chapter here. Chapter 44 is pediatrics. 45 is another. We have a couple chapters yet to go in the medicine section, or actually the special patient section, to be specific. But OB and pediatrics tend to be some of the biggest and most intense chapters late in the course. So we'll get through pediatrics here and hopefully be smooth sailing the rest of the course. Just like with all of our chapters, if you have not read and studied the chapter on your own, you need to do that. Simply watching and listening to the lecture is no replacement for that. Again, I'll apologize for being a little under the weather, so my normally annoying voice is probably a bit more annoying at this point, so I apologize. Chapter 44 will start to cover, or actually will cover pediatric emergencies. For the most part, another chapter we're going to touch on, which is special patient populations, does have a little bit of emphasis on pediatrics as well, because we tend to see quite a few pediatric patients in the home with special healthcare needs. So, but we're not completely done with pediatrics after this chapter, but we're going to hit the solid majority of it right here. Our advanced education standard again says that the AEMT will be able to apply fundamental knowledge of growth, development, aging, and assessment findings to provide basic emergency care, transportation, and selected advanced emergency care for a patient with special needs. There are 3 multimedia videos that you can watch in the non-narrated PowerPoint. One's communicating with toddlers. Basically, you need to know that they know one word, which is no. Actually, I'm kidding. But a good one that kind of talks about talking to patients that aren't at the same developmental level, of course. Caring in an empathy video, and then, of course, the SIDS video. There's several things in this chapter which are not particularly fun, happy, or exciting, but we certainly do run into them. A ton of objectives for the chapter found on 971, 72, and 73 of this chapter. So we will skip through those. All right, our introduction. Caring for the critically ill or injured child can be very stressful for the EMS provider. I would say it is the most stressful situations that I have run into. I really believe, truly, that only one call has affected me enough that it caused me to lose any sleep. Now, maybe collectively they've all taken their toll on me over the last couple of decades, but there's only one call I can identify that specifically gave me some issues, and it was actually 2 pediatric patients in one, and it was a really sad situation. So at the time, I was a young father of children of similar age, and so it hit home especially hard after that call. We have to also take into account the differing epidemiologies of illness and injury in children, understanding that they're not as likely to see the same problems in the pediatric population than we do in the adults. We know that kids generally have good, strong hearts, but it's their lungs that give them issues, or it's their immature neurologic system or their immature immunologic system that gives problems. We understand that there's also anatomic, physiologic, and psychosocial differences that we have to take into account when we evaluate a presenting problem. It goes with your case study. Okay, briefly, now way back in the beginning of the course, we talked a bit about growth and development and excuse me, growth and development and how people will change as they age. We went all the way up through late adulthood, and so we're going to touch on a little bit of that again now. So some major concerns for anatomic and physiologic differences in children and infants. Children's heads are proportionately larger. The younger they are, the more out of proportion they're going to be. So they have these large heads, which tends to make them top-heavy. And with their top heaviness, as well as their immature neurologic system, which helps coordinate, and a not so well developed musculoskeletal system, that makes it very difficult for them to be well coordinated for many years into their childhood. The temperature control mechanisms in the hypothalamus are immature, and particularly in babies are very unstable. Hence the reason why we work so hard to keep babies wrapped up and warm so they're not becoming hypothermic, using up all their sugars and switching into some anaerobic metabolisms. Children have smaller airways with more soft tissue and narrowing at the cricoid cartilage, and the openings of the trachea and the esophagus are closer together. We've got to remember that a child as a whole has to ossify their bones and have to strengthen their cartilages as they grow. I've mentioned many times throughout the course that taking an x-ray of a child, you might see faint shadows of where the bones are, but don't see near the nice, crisp, stark differences that you see in an adult's bones. It's because they haven't calcified, they haven't deposited the phosphates as well to make their bones and their cartilages strong. So that has an effect on the trachea as well, because it doesn't have these cartilaginous rings that circle it in a C shape and keep it strong. That cartilage is still very floppy and flexible. Obviously much smaller, and with the big head compared to the smaller body, you go from having the top end of the airway being wider than the bottom end, so it's funnel shaped. Children have faster heart rates and respiratory rates both. They tend to have lower blood pressure. Temperature tends to stay pretty close to the same. Children have less blood and therefore are in danger of bleeding to death from a relatively minor wound or developing severe shock. A small infant has the blood volume that's approximately that of about a pop can or a pop can and a half is all the blood volume that they actually have. So they very easily can lose that. Children dehydrate very easily. Again, they have difficult time with their thermoregulating systems. They're not always as key in tune with their senses saying, hey, I'm feeling thirsty. Not to mention if they become ill, they have a much greater chance of vomiting a lot and having diarrhea, which makes them dehydrate all that much faster. And then young children's extremities are likely to appear somewhat mottled, and this is in response to the cold due to their temperature control mechanism. It's not necessarily a result of poor circulation. All right, so infants. Infants are that 1 month to 1 year of age. If you recall from the last chapter, that first month, that first 30 days of life, from the time of birth through 30 days, they're referred to as a neonate. So that 1 month to 1 year of age, body systems are all extremely immature. They have a very large liver compared to the size of their abdomen, and their abdominal wall is very, very thin. Hence the reason why they can't sit up for several months after birth and even consider to do things such as crawling and or walking. They have to develop some of those muscles. So that whole straining thing that they do, and they're straining to get their head up and whatnot, in many cases that's what they're actually doing, is they're working to strengthen many of their abdominal muscles, their neck muscles, their back muscles, chest muscles, and so on. The ribs are very pliable, like I mentioned, and they're not ossified. They have not had the benefit of being receiving deposits of nutrients, electrolytes, for 10 to 20 years. The kidneys don't do a great job of concentrating urine. That's why babies pee a lot. It's just the water kind of running out. They're still immature yet. Vessels are still forming and still strengthening. The bones are softer. The skeletal muscle mass is very small. They do have a little bit of a baby fat around them that kind of serves as a bit of an insulation, but under that fat there's not much muscle. The base muscles are generally there, but of course it takes years to develop them and to grow them into a stronger, healthier kid. Again, this very disproportionate head, very weak neck, and then a greater surface area to volume ratio that increases the heat loss from the body. With the giant noggin, which in infants usually doesn't have a whole lot of hair on it, so there's not a lot of an insulating factor there, there's a great chance that they're going to lose much more heat through their head. And then not to mention, with their difficulties with their thermal regulation in the hypothalamus, their difficulties with maintaining fluid volumes, the whole process just leads to changes in either hypothermia or even occasionally hyperthermia in our infants. The airway is very easy to obstruct. Just think of this: a regular little pea is large enough to easily large enough to obstruct the airway of an infant. So one pea, not in the pod, outside the pod, and the tongue takes up this giant amount of space in their oral cavity. Obviously, many times it seems to be sticking out of their mouth. They have a very small, very soft nose. Doesn't have a lot of underlying structure to it, and so therefore with this very little nose that is kind of floppy and flexible, a little bit of mucus in there causes a great deal of problems. They have very fragile lungs. They're very easily damaged. Remember, that's one of the very last things that is developed before the child is born is those lungs. So it's easy for them to come down with some respiratory tract infections, as well as some ugly things like RSV. Respiratory failure and arrest occurs quickly in infants because they are so weak in the lungs to begin with, yet still have such high metabolic demands as they grow. Loss of adequate respiration and ventilation takes a very, very quick toll. Water vapor is lost with every breath, as it is with adults, but again, we're talking proportion size here, and this is going to lead to some dehydrations, particularly when you couple it with poor feeding, vomiting, diarrheas, and fevers. You're going to see good chances for dehydration. We'll touch on it in a minute, but one of the best questions you can ask the parents of an infant or a small toddler is, how many diapers have they had today over the past few days, and what's normal? Because yes, we're not going to have a really good idea how much output they truly had. Very few people, if any, measure their urine output at home. But to ask about diapers, do they seem to be as heavy as they were or as full as they were, can give us a lot of great information that, hey, yeah, urine output is apparently down. That's why when you go into hospitals in the pediatric wards, you will see scales in each room, and that's for them to weigh the diapers, and it's for them to basically track fluid intakes and outputs. A very immature immune system. While they did obtain some immunities from their mother, which lasts for up to around 6 months or so, they still have a very, very vulnerable immune system. That's why they get so many shots, particularly in that first year, but even throughout their first several years of being a toddler as well, is to help build that immunity. Fever is always a concern. Now, fevers are fairly common in small children. Doctors have done a good job of educating many parents on how to handle them, but higher fevers are always a concern. and crying is their only way of communication. They cannot tell us they're hungry, they're wet, they're uncomfortable, they're in pain, they feel like they're going to throw up, which I think is always, but so their only way to communicate is to cry. Toddlers and preschoolers. So toddlers and preschoolers, toddlers are ages 1 to 3 and preschoolers 3 to 6 essentially. The head is still proportionately large, really until they get into really school age do they start to become more proportionate. Their airway is pretty small. It's easily obstructed. Even a 2 or 3 year old, not much larger than a bean, would close off their airway. They're still vulnerable to communicable diseases, and now that we're getting into being toddler and preschool age and then on into school age, we're around more and more kids and we're exposed to more and more things. Just due to the diversity in our culture, we're going to have people that are exposed to different things. And this is honestly a good thing. Exposing the kids to different types of germs actually helps them build a stronger immunity and lessens their chances of asthma. So this has been proven. We have in society become so over the top on many of our antibacterials, and I want an antibiotic, and oh, I better take a bath in Purell hand sanitizer, that we've really wiped out so much of the flora and fauna around us that we don't ever build up any immunities to them. So they can become very opportunistic once we get knocked down, and we get truly sick from something like the flu or a pneumonia. Then they can become opportunistic and then really hit us hard. Ear infections, upper and lower respiratory tract infections are very common. Ear infections in the bottle feeding, particularly the infants, many cases are simply for the fact that through feeding they get a lot of backup into their eustachian tubes up into their ear canals, and that's what actually causes many of those ear infections. So a lot of younger children end up with tubes in the ears to allow those ears to dry out. But the respiratory tract infections tend to be some of the most common, and whether it's something as simple as a common cold or something as ugly as like a influenza or RSV, many of those things have the potential to really knock kids down for a little while. There's a communication with toddlers video. So croup, bronchiolitis, pneumonia, epiglottitis, all of those are very common childhood diseases, although epiglottitis is becoming less common as a childhood disease. There's some pretty good immunizations out there now that are doing a pretty good job of protecting people from epiglottitis. But and even some pneumonia shots, although pneumonia shots aren't routinely given to kids, they're routinely given to people who are at risk and immunosuppressed. So, but all these have the potential to hit a kid, and obviously it wipes them out pretty hard. Strangers can provoke anxiety at this age, because in the infant level, yeah, the infant probably has an auditory memory of what their parents and their loved ones sound like, but remember, their abilities to focus are not very good either. And it's not until they get older that they start to develop that whole sense of stranger danger. So one of the best things we can do is establish a rapport and gain the child's trust and communicate with them in a way they understand. And in many cases, this also involves the caregiver. So getting the caregiver involved in the patient's care, and maybe we'll take a blood pressure on mom, and then we'll take yours, okay? And we're going to put this on your arm, and it's going to give it a little squeeze. We move on to school-age children, which are generally 6 through 12 years of age. They're more proportionate now. their approval and acceptance of others is important, because now the social aspect starts to develop within the child. The peer groups and does somebody like me or somebody doesn't like me, that all becomes very important in this age group. They are starting to develop understandings of illness, death, dying, trauma, pain, and whatnot, and need adults' assistance in coping with their fears, because they don't have experience really, they don't have much experience in trying to actually interpret how they really feel about some of these things. They generally have a need for some modesty and privacy, so they've been taught a lot, this is good touch, this is bad touch, and so on and so forth, and so that weighs on them. They think about those sorts of things, and so it becomes important to them that we consider their needs there and their privacy. So if we have to look at something, then we have to consider covering it back up or replacing the missing clothing there, so we can respect that modesty. And of course, adolescence, 12 to 18 years of age. Obviously, it kind of depends legally, from a legal perspective, depends on what state you're in. In Nebraska, they are considered a minor until the age of 19. So in Iowa, it is 18. But the vital signs are very close to that of the adult values. In many cases, they get treated as adults because of their growth is nearing completion. Now, psychosocially, this is a very difficult time period, and even though they may appear to be done growing, there are still parts of them that are going to continue to develop well into their 20s. So, the child actually enters adolescence when they begin puberty, and so that age of 12 is kind of actually arbitrary, depending on what time it actually hits them. Boys, it tends to be a little later than it does in girls. So some girls are probably around the 9, 10, 11, 12 age group or age range when they start to hit puberty. Boys may be 11, 12, 13, 14, maybe even sometimes 15, that they start to hit their puberty. So they're not legally capable of making medical decisions until they've reached the age of majority in your state, unless they have one of those other few exceptions, such as being married or a parent or being emancipated, so on and so forth. And yet the brain has not developed, and I keep mentioning this. Emotionally, they're still kind of unstable. They're still developing emotionally. And parts of the brain that are really particularly at risk are the areas of the brain that have to do with the concepts of addiction. They have a sense of invulnerability, even though they don't want to show it. They, in many cases, want to act like they're invincible, but in many cases they know that they are not, and they but yet still engage in risky behaviors. The rates of depression and suicide obviously increase because before you're 12 years old, everything's cool because it's basically go to school and play a lot. So once you hit adolescence and you're starting to develop relationships, that's when you start to see those things start to increase, particularly as you get more and more responsibilities placed on you. The assessment and management of the AEMT, very similar to that of adults. And keep in mind their psychosocial differences. Still very, very immature. In fact, I think that even in my 40s now, when I was in my 30s, I was probably still pretty psychosocially immature. But it's kind of amazing as time goes on, because I was pretty sure at 18 I knew everything there was to know. Rapid growth and development make pediatric patients differ according to their size and their age. So we have to keep some of these things in mind. we need to have a selection of equipment on our trucks. And we have this list that's coming up in one of the slides coming up. Actually, it'll be the one after this one. That is the same as the list on 975, and it talks about having appropriately sized equipment. So we can deal with different sizes of pediatric patients as well as adult patients. So the principles of seeing size up remain the same. Many of the principles of assessment remain the same. We just have to make maybe some minor tweaks. But when we're looking at equipment, something like the Broslow tape, and I'll put something in the course page that kind of shows you how that Broslow tape works. But the Broslow tape, or a length-based measuring device, or I don't remember exactly how they term it, but what this basically is a folded up, plasticized piece of paper that you can stretch it out much like a measuring tape. And you start at the patient's head and you stretch it out, and wherever their feet stop on this tape, you look at that color group or that age range for their height, and it tells you what size oral airway to use and what size blood pressure cuff to use and what the normal vitals should be and what this dose is and that dose is. And they're kind of a handy device. The sad thing is we also need one that accounts for how big around they are, but that's a whole nother story. So the Broslow tape has been picked up and ran with. It's probably very limited in its use at, say, the basic levels. It's particularly helpful at the advanced levels when you're talking about most of your drug ranges or drug doses are based off of their weight. So we have things such as pediatric stethoscopes. I talked about having a neonate stethoscope in the last chapter, where the head of that neonate stethoscope is roughly about the size of a nickel. Pediatric stethoscope, where you've got a head on the stethoscope that's probably around the size of a quarter, makes listening to that age group a little bit easier. Blood pressure cuffs in a variety of sizes. There are many, many, many sizes of blood pressure cuffs. It does not make sense to have 40 sizes of blood pressure cuffs, but have some of the more common ones that you may use on hand so you can appropriately assess your patients. A lot of people want to default and say, well, I didn't take a blood pressure on them because they were under the age of 3. Well, in theory, I get what you're saying, but if you've got the equipment, you have the capabilities to take the blood pressure. If you don't have the equipment, then default to the capillary refill. Pulse ox sensors, because remember that adult size sensor is huge. Sometimes on those neonates, we can put the whole finger sensor over a neonate's foot. Different types of airway devices. The King airways are coming out eventually with the smaller sizes for smaller children. Oxygen masks, bag valve masks, cervical collars, or a variable size or an adjustable size collar, bulb syringes, blankets, 60 drop IV sets, because when we're talking about giving fluids to a pediatric patient, we have to be careful because we're talking small amounts of volume in many cases. A volumetric IV device such as something called a Buretrol. The Buretrol basically has a detailed measurement device that looks like a rain gauge, basically, installed in the tubing. So you'll drain some of your fluid out of your bag into the graduate, which is what is referred to, or the actual Buretrol itself, and you'll be able to measure milliliter by milliliter, basically, how much fluid is in there, and then you can accurately dose your fluid that way. Small gauge catheters, such as 24s, 22s. They also make you 26 gauge catheters, so depending on what your service has access to. 25% dextrose, 10% dextrose, those are not always real commonly carried on EMS. You can make your own. I've talked about how to do that. So it's simply diluting it. D50, 50% D50, 50% normal saline, you have D25. With D50, if you do 20% D50 and 80% normal saline, you have D10. Pediatric size splints and some sort of a restraint device to be used for transport. Also, another good thing to put in there is a pediatric immobilization device, various different pediatric backboards and whatnot. So just because you're responding to a pediatric patient, don't let that distract you too much. Yes, you're going to be nervous, I guarantee it. So, but take advantage of your response time to take a moment and say, okay, well, we're going to a pediatric seizure. They said 4 years old. So what does that mean? Let's look up what a normal 4-year-old's vital signs should be. Let's look up how much fluid or what size a normal 4-year-old might be. So if we need to give them a bolus of fluid. Let's whip open the protocol book and look closely at our pediatric seizure protocol. So that's an opportunity to help you brush up a little bit before you get there. Yes, you should know all those things. Yes, you should have a base knowledge of them. But this, again, is not a patient population that we deal with on a real regular basis. So it's understandable. And we have anatomical differences that alter the patterns of trauma. Remember, a 2-year-old being struck by a car and a 22-year-old being struck by a car have totally different injury patterns. So we got to keep that in mind. All right, Caring and Empathy video, you can watch that in the non-narrated PowerPoint. So our general scene size up and our assessment. Take into account the reactions and the needs of the parents and the caregivers. This is often just as hard, if not worse, on the caregiver than it is on the child. Granted, they're situationally dependent. Sometimes we have the weird things like an abuse situation in which that's going to have a completely different tone. Unless the parent is unable to cooperate, no reason to separate the parent from the child. I kind of mixed feelings on this statement for the fact that sometimes we need to take the parents away from the child, just for the simple fact that the parents are losing their minds. And I guess that's the part that goes with the cooperate. If you have the option to take one parent or the other, take the calmer of the two and try to get somebody else to drive the parent that's losing their mind to the hospital. Let the parent know what your thought process is. Say, look, I understand you're terribly concerned, and I value your input and I value your feelings, but when your child sees you being so upset and so over the top, it worsens the situation for them. Allow the parents to participate as much as possible, because that helps gain the trust of the child as well. So use them to hold an oxygen mask or use them to help you splint. Don't forget, child abuse and neglect sometimes is the underlying tone that we didn't get called for child abuse. We don't generally get that call. We get called for a child who fell down or a child who got hurt, broken arm, what have you. So some indications of child abuse and neglect just to keep in mind. Injuries that are inconsistent with the history provided. Bruises over the soft areas, so buttocks, abdomens, cheeks, thighs, upper arms, as opposed to the bony areas. So foreheads, shins, elbows, knees, those are common places to get scratches and bruises. I remember as a kid myself constantly having scraped up knees. Kids fall down, kids are out being kids, and that's what's supposed to happen. I don't know if that's as much the case anymore, because you might get rug burn from sitting on the carpet playing Wii or PlayStation or whatever, but at least when I was a kid, we were always out dinking around and scraping up ourselves. Multiple injuries in various stages of healing. So we see lots of bruises with lots of different colors. They used to say you learned a particular order in which bruises changed colors, and they would say that, you know, if it was a bluish black bruise, it was so old. If it was greenish, it was a little older. If it was yellow, it was even older than that. That was proven to be unreliable, so they don't discuss that anymore. But you generally will see them age about the same. So if you do have purple and blue bruises and some green bruises and some yellow bruises, there's a good chance that there's various stages of healing there. An unusually fearful child. So if you come at them and they real quickly shy away. Specific patterns, cigarette burns, hand marks, belt buckles, bite marks, etc. Clearly delineated burn marks or burn marks in the shape of a specific object. Things that are don't show evidence of accident. So if we would have a child with what we refer to as stocking burns, so it looks like their feet have socks on, we will keep in mind that that kid didn't step into the tub and stand there. Because if the kid stepped into a very hot tub, they would splash around. And when they splash around, they get the splash burn on them as opposed to a nice, fine, delineated shape. Injuries to the genitals, lack of adult supervision, untreated illnesses, delay in reporting certain illnesses and injuries, malnourishment and lack of food, sexual behavior or unusual knowledge of sexual activity, and a generally unsafe living environment. Okay, this item that we're seeing on the screen is the pediatric assessment triangle. This is also on page 976 in your text. But the pediatric assessment triangle is a tool that we use to quickly, really from across the room, assess the patient and get a general impression of our pediatric patients. So this is actually a very nice little tool that we can use here. So we're going to talk about each one of the little components here in just a second. But again, like I said, in many cases this is really done from across the room. It is not something you even have to really lay your hands on the patient. So we're looking at things such as appearance, work of breathing, and circulation of the skin. So you just have to remember to replace airway with appearance, and it's really very similar to our ABCs. All right, so continuing with our scene size up, the potential for abuse or neglect require a law enforcement presence. We're going to keep that in mind. When the child abuse or neglect or sudden infant death syndrome, SIDS, is suspected, we need to document the heck out of that because there's going to be investigations, there's going to be law enforcement involved, perhaps a coroner or a medical examiner, depending on the state that we reside in. We'll be doing an investigation to make sure that everything's on the up and up. Remember, SIDS is generally considered a diagnosis of exclusion, meaning that when everything else has been ruled out and there's maybe a couple of characteristics that are found common to SIDS cases, it will usually be ruled SIDS. And remember to use your pediatric assessment triangle to formulate your general impression of your patient. So the first part of the PAT is the appearance. Things that we look at under appearance include items such as muscle tone, interactiveness, consolability, and eye contact, and speech and or crying. Those sorts of things we are going to look for what's normal for a kid of that age. So are they holding themselves upright, or are they slumped over on the couch, slumped over in mom's lap? Are they make eye contact with us when we come in to the room? If we say something to them, do they react to us, or do they just kind of stare off into the distance? Is the mom or dad able to help calm this child down? Work of breathing. This is abnormal airway noises, abnormal positioning, abnormal retractions, nasal flaring, or increased work of breathing. Those sorts of things help us make a determination, hey, there's probably something going on with the airway and or breathing here. And then finally, the circulation to the skin. The circulation of the skin is what is the skin's color like? Do we see any severe bleeding? And do we see pallor, mottling, cyanosis? So pallor, mottling, or cyanosis could be signs of poor perfusion in the child. Notice it doesn't mention anywhere heart rates and respiratory rates and whatnot. This is simply making a doorway assessment of our situation and then using it to guide the remainder of our assessment. So in our primary assessment, of course, if we have an unresponsive, not breathing, or not breathing normally, confirm that they are unresponsive, check for a pulse. So in the infant, that will be in the brachial artery. In an older child, that will be in the carotid. And if a pulse is not detected within 10 seconds, then begin chest compressions. Reminder over pediatric CPR. A child 1 to 8 years of age, where actually the American Heart Association is actually changing that top end. Instead of saying 8 years old, they're now saying the development of secondary sexual characteristics, so breast buds or pubic hair, or axillary hair. So once the child has started into puberty, they say, you then switch to adult CPR. So indication and initiation for the child: they're unresponsive, they're not breathing or have agonal breathing, no pulse or a heart rate less than 60 with very poor perfusion. A lone rescuer performs 2 minutes of CPR, then activates EMS. The EMS team should perform interventions simultaneously. The reason that they do this for infants and children, that CPR first, then go call, is sometimes just that first 30 or 60 seconds really does the resuscitation, really does wonders to bring the kid back. Hand position: 1 or 2 hands, depending on the size of the child, over the lower half of the sternum. Compressions: around 2 inches or at least 1/3 of the anterior posterior dimension of the chest. So 1/3 the thickness of the chest from front to back. Compression rate of at least 100 per minute. And the ratio of compression to ventilation: 30 to 2 in one rescuer, 15 to 2 with 2 rescuer. And in the infant, less than 1 year of age, if they're unresponsive, not breathing, or agonal, or no pulse, or heart rate less than 60 with poor perfusion, again, lone rescuer does 2 minutes of CPR prior to activating EMS. EMS is performed simultaneous interventions. The hand position is 2 or 3 fingers over the sternum, just below the intermammary line, or the just below the nipple line, or 2 thumbs encircling if you have 2 rescuers present. The two thumb encircling technique works best if you don't have to constantly move your hands to ventilate. And we're going to press 1 to 1.5 inches in depth, or at least 1/3 the anterior posterior dimension of the chest, again at a rate of at least 100, and the ratio will still be 30 to 2 for 1 rescuer, or 15 to 2 for 2 rescuers. The most common cause of cardiac arrest in pediatric patients is hypoxia due to respiratory failure and respiratory arrest. The AHA allows for EMS provider judgment in making ventilations higher priority during CPR. So you're going to need to know what your protocols are and follow those. If the patient is responsive or unresponsive but breathing, then continue to assess your ABCs. Good reminder here of how the child, and this is actually getting close to school-age child here, how the child can have a much larger head in comparison, and by allowing the child to lay flat on their back, actually hyperflexes their neck or pushes their chin forward, so it angles their airway out of alignment. So by taking and folding up a towel and placing it beneath their shoulders, that towel needs to be probably 1 inch to 2 inches thick in most cases, will kind of put them into a normal alignment so that the airway is much easier to maintain that way. Some of your pediatric immobilization devices, pediatric backboards, have a built-in dip up by the head, so it allows the head to kind of relax back. The primary assessing for partial or complete airway obstruction, this can be a big thing in the pediatric population. Pat under the shoulders, particularly of smaller patients, and then assess the need for assisted ventilations. Sometimes we need to assist a little guy just because they're not, they're wearing out and they don't have the strength to continue. Be prepared to intervene quickly with a child who has signs of respiratory distress. These really aren't much different than those of the adult. We add a few things such as seesaw respirations or nasal flaring, which are kind of more common to kids. If hypoxia is evident or likely, then provide some supplemental oxygen. And here they show administering some oxygen to an infant via blow-by. So they've stuck an oxygen tubing in the bottom of that little paper cup. Baby looks pretty stinking sick, so it's kind of cute. All right. Face masks, generally not appropriate for infants, may not be tolerated by toddlers. In many cases, unless the kid is really young and really sick, you're going to have a hard time getting a mask on a patient. They just don't want things touching their face. So use blow-by oxygen when possible. We've talked a couple of ways to do that. Introducing an oxygen tubing into the bottom of a cup. There's some commercial devices, even using an oxygen mask. And if it's a non-rebreather, take the valve off from the inside at the top of the bag so oxygen freely flows. You could even throw together your nebulizer and use that, whether you use a mask or if you use the peace pipe. Just remember to block the mouthpiece end of the peace pipe, and that'll have oxygen directed then in their face, roughly a ½ inch from their face. Children's blood volume is going to be small, so shock can occur with very little volume loss. Controlling hemorrhage, being highly suspicious for any internal bleeds, and then keep the patient with blood loss warm. It's just like treating for shock in adults. We do the same things. So what are the signs or symptoms of shock/hypoperfusion in an infant or a child? Really, they don't change much from that of an adult. So it would be things such as excessive tachycardia. We're going to have to consider how fast is the heart rate normally for a child of that size. So, still talking about things such as minor tachycardias, increased respiratory rates, anxiety, modeling, pale, cool, clammy skin. They continue to be very similar to that of the adult. As we proceed on to the secondary assessment, younger pediatric patients have an inability to give a chief complaint. They have very limited language skills to elaborate on any chief complaint, and medical history is not going to be something that they're even going to have any idea about. So it's really going to be one of those things that we're going to have to rely on caregivers to give us additional information so we can get a sample. OPQRST can be very difficult in kids because they're not going to understand, tell me what your pain feels like. That just doesn't work in the younger populations. How bad is it? We might use the Wong-Baker Faces scale, which is for the really crying face cartoon all the way up to the very happy cartoon. And it's usually like 5 or 6 or 7 faces on this little scale. But they're even seeing that that's maybe not even accurate, just to have the patient try to point. So does it hurt a lot? Does it hurt a little? That's better than nothing. Look for any specific history questions to ask. So are they displaying normal activity levels? Or are they sleeping all the time? Any recent fevers or illnesses? Any recent hospitalizations, injuries? Have they had any rashes, or do they currently have a rash? The volume of oral intake and their urinary output. So again, bringing back that diaper question. Diarrhea or vomiting, current and past medical problems, birth complications, were they premature, and are they up to date on their vaccinations? Not always are these going to have relevance to us immediately in the field, but we may be able to start to piece things together and pass that information on to the hospital staff. So using their level of responsiveness that we determine via the AVPU, we're also going to use potentially use the pediatric Glasgow Coma scale as a more precise form of assessment. You can see the pediatric version of it on 980 in your text, which we're going to look at here. Eye-opening really stays about the same. For the greater than 1-year-old as it is to the adult. It's really AVPU. For eye-opening in the infant, they say spontaneous eye-opening, shouting, pain, and no response. So it really, in a sense, is exactly the same. Motor response for a greater than 1-year-old, if they can obey a simple command, do they localize pain or show you where it's at? Do they flex to withdraw from the pain? Do they flex abnormally or have decorticate rigidity? Do they have decerebral rigidity or no response? And then in the less than 1-year-old, they can't get a 6, but 1 would be localizing pain, or less, yeah. A 5 would be localizing pain, 4 would be flexion withdrawal, 3 flexion abnormal decorticate, 2 extension decerebral, and 1 no response. And for verbal, we will use in the 5-year-old and above, oriented and converses, disoriented and converses, inappropriate, incomprehensible, and none. The 2 to 5-year-old, appropriate words and phrases, inappropriate words, cries or screams, grunts, and none. And under 2 years of age, smiles, coos, cries appropriately, cries, inappropriate crying or screaming, grunts, no response. I don't think there's any secret. I am not a fan of the Glasgow Coma scale. I feel it is a far too limited tool, yet it continues to be a standard. Secondary assessment, know the normal values of pediatric vital signs. And we have a table here that we can look at. Hopefully you guys all have some sort of a pocket resource, pocket guide, flip guide, phone resource, iPad resource, whatever, that you can use when you go on calls. Take copies of this and post it in the ambulance, laminate it, whatever, stick it in a page protector. When you're on your way to this call, take a look at it. Say, okay, I got to remember what the norms are for this various age group. What's normal vitals for a toddler? 24 to 30, 80 to 130, 72 to 100 for a systolic pressure, and 98.6 to 99.6. Okay, that's easy enough. So I've got it in my head, and I'll know if I'm close. Blood pressures can be difficult to obtain in the less than 3-year-old. Most of the time, the reason why it's so difficult to obtain is because we don't usually have the right tools. So in some cases, we will substitute capillary refill in. The capillary refill time should still be less than 2 seconds. A delayed capillary refill of between 2 and 4 seconds can tell us that the patient has some compensated shock. And if it's greater than 4 seconds refill time, generally indicative of decompensated shock. So we base our physical exam on the chief complaint. So we're going to look for things such as unusual lethargy or a flat affect. The affect is their behavior and their attitude. So if they really are just kind of deadpan, monotone, that's a flat affect. They lack interest in their surroundings. They're just kind of existing. That's unusual lethargy. Unusual patterns of bruising, injuries, and unusual to the child, unusual patterns or locations. Look for things such as rashes or petechiae. Remember, petechiae was those little pinpoint capillary bursts, whereas purpura were the larger splotches. The absence of tears may be a sign of dehydration. Lack of urination or lack of change in diapers also could be. Drainage or bleeding from the ears, signs of possible toxic ingestion such as burns around the mouth. In the infant, we're going to look for things such as bulging fontanelles or depressed fontanelles. Mainly the anterior fontanelle, so that's the one that's just in front of and directly above your ears. That usually stays open until about age of 18 months or so. So that's going to be bulging if they have an increased intracranial pressure or are screaming and crying, and it may be depressed in the child that is dehydrated or shocky. Distended abdomens. Remember, most little ones don't have a lot of belly fat there, so it's usually much easier to determine whether they have abdominal distension versus it is of many adults these days. Does the child favor, protect, or refuse to use a certain extremity? So be prepared to change your general impression and your patient's priority for transport. Sometimes we get a little nervous going in and we jump to a conclusion pretty quickly, and after we reassess and do a little bit more in-depth digging, we come up with, well, this maybe isn't so bad after all. Or vice versa. Sometimes it ends up being worse than we originally thought. Understanding that epidemiology of illnesses and injuries are much different in children than that of adults. I've used the old adage that the first 40 years, the stupid things you do in your first 40 years are the things that kill you then, and the stupid things that after you turn age 40, it's payback from the stupid things you did before you were 40. So, heart disease starts to affect people in their 30s and 40s, whereas most heart disease is, unless it's a oddball congenital thing, not a problem with most kids. And remember, pediatric populations compensate very well for illness and injuries, but once they're done, they're done. So kind of when a pediatric patient goes into a shock state, they compensate, and then drop off just like they fell off the end of a cliff. Whereas most adults, as they deteriorate, they gradually deteriorate, kind of rolling downhill as opposed to directly falling off the end of the cliff. Pediatrics also have very limited energy stores, therefore that's why they deteriorate very quickly. They use up all of their backup, and then they have nothing else to rely on. Remember to remain highly suspicious of mechanisms versus natures, and whenever possible, transport to a pediatric emergency department. Now, if you're outside the metro area, that is probably not going to be an option. Now, if you know of hospitals that will particularly admit kids, great. Take the kid to the hospital that has some pediatric resources. Most of the smaller town hospitals, what are referred to as critical access hospitals, most of those hospitals will admit kids, but don't particularly have pediatric specialists. The kid is going to be seen by a family practice doc. In the city, we'll take Omaha for example. There's really only about 3 hospitals that will admit pediatric patients for inpatient use, or inpatient care, other than the obstetrics units, which the child is born there. For the most part, the child does fine. If a child is born there and isn't doing well, that kid gets shipped immediately. So, so know that not something that a lot of hospitals want to hang on to is pediatric patients. Treatment: consider using the various pediatric-sized equipment. They keep bringing up the LMA here. The LMA, again, not probably an appropriate tool for pre-hospital use. Remember, you have to reduce the volume that you give a child. You basically have to really pay attention to the chest rise and fall to know what the appropriate tidal volume is. But also we have to kick up the rate of ventilation. So we want to have higher rates of ventilation, so usually knocking on that 20 to 30 range, and just simply watching for the chest to rise, start to rise, is knowing that's our end point for ventilation. So, talking pediatric bag valve mask, the neonate, we're going to ventilate at roughly 30 per minute, 6 to 8 mils per kilo. That's a good. Using 7 mils per kilo is almost a perfect number to put yourself into. 7 mils per kilo. So approximately 20 to 30 milliliters is all that a neonate needs, which is roughly that of a shot glass. Or if you puff your cheeks out, that's about all the air they need, the air you can hold in your two cheeks. So use a bag valve mask with no greater than 250 mils of volume, if at all possible. In the infant, respiratory rate of 20 to 25, still 7 mils per kilo, so we're talking somewhere with 20 to 80 mils. Use the pediatric size bag, or infant usually will work here as well. The 250 to 500 mil volume. And then the child, ventilatory rate of 12 to 20, still 7 mils per kilo, so we're talking roughly 70 to 200 mils. So we're talking less than that of a pop can. So we don't need huge volumes for these kids. If we have to spinally immobilize them, place padding under the body to avoid that hyperflexion of the cervical spine. Use appropriately sized C collars and splints. Sometimes we have to improvise. If dehydrated, consider IVs or IOs. And remember that we replace fluids in kids at 20 mils per kilo. Our pediatric patients will deteriorate quickly, so reassessment on a regular basis is a must. We're going to compare subsequent findings to our baseline vital signs to help identify trends. Remember, you can't say vitals are stable if you only took one set. And then we're going to continue to monitor the effects of any treatments we gave. All right, assessment and management of pediatric patients require appropriate equipment, plus the knowledge of different patients between adults and pediatrics. And otherwise, you will rely on many of the same principles of assessment and management that you've already learned.